All right, welcome to this explainer from the Surgical Edge podcast. Today, we're diving deep into one of the scariest things you'll see in a surgical career, necrotizing fasciitis. We're going to break down the key differences and the critical similarities between how UK and US guidelines tell us to tackle this absolute beast of an infection. So, let's jump right in.
Okay, but first, the really important bit. This is a disclaimer. Everything we talk about here is for educational and reference purposes only. When you're in the thick of it, you absolutely have to follow your local protocols, your hospital's guidelines, and, of course, your own clinical judgment. This is just a tool to help you think.
So, here's what we're covering. We'll start with why it's a true surgical emergency. Then we'll look at diagnosis, suspicion versus scores. After that, workup. Do you scan or do you cut? We'll hit the three-pronged attack of management, what happens after the debridement, and finally, we'll wrap up with the universal truths that apply no matter where you practice. Okay, Section 1. Let's all get on the same page here. It doesn't matter if you're in London or Los Angeles, necrotizing fasciitis is a terrifying, life and limb-threatening infection. The clock is your biggest enemy. Speed is everything. And let's laser focus on the single most important clue. If your patient has pain that is just completely ridiculously out of proportion to what you're seeing on their skin, that is the alarm bell. It has to be ringing loud and clear in your head. This is the classic #1 red flag that both guidelines absolutely agree on. Of course, that crazy pain is just one piece of the puzzle, right? You're also looking for a patient who is systemically unwell. They've got a fever, they're tachycardic, their skin is changing fast, maybe going from red to a dusky purple. And you might even see these really ominous dark blisters or bullae. Now, late signs like crepitus, that crackling feeling under the skin, or when the skin goes numb, those are super specific. But honestly, the goal is to get this diagnosis long before you ever get to that point. All right, Section 2. And this is really where we start to see the first big split in how things are approached. While everyone agrees that your clinical suspicion is king, the guidelines differ on the tools you might use to back that judgment up. So over in the UK, the guidelines actually promote using something called the LRICNE score. It uses pretty standard blood tests, we're talking CRP, white cell count, sodium, that kind of thing, to help stratify the patient's risk. The magic number is 6. A score of 6 or higher should really heighten your suspicion. But, and this is a huge but, the guidelines are crystal clear that a low score does not rule out NF if your gut is telling you something is wrong. You always trust your clinical instinct over the score. And this really gets to the heart of a difference in philosophy. The UK sees the LRNX score as a helpful tool, another piece of data to help stratify risk. The US guidelines, on the other hand, put a lot less faith in it. They point to its variable sensitivity and really double down on relying almost entirely on pure clinical acumen and that classic sign, pain out of proportion to the exam. Okay, Section 3. So you've got this high suspicion of NF. What's your next move? Do you rush the patient to the CT scanner, or do you rush them straight to the operating theater? This is a huge decision point. And yeah, you guessed it, the guidelines diverge a bit here, too. So let's think about this. When it comes to actually, definitively, 100% diagnosing this disease, amidst all the clinical uncertainty, what is the one, undisputed, gold standard test?
It's the scalpel. That's it. Surgical exploration is both diagnostic and therapeutic. It is the only way to know for sure, and it's the first step of the treatment. There is absolutely no substitute.
And you can really see this reflected in their different takes on imaging. The UK stance is incredibly clear. It's a mantra. If your clinical suspicion is high, you go straight to theater. Any imaging that causes a delay is a bad idea. Now, in the US, while that same principle is still the gold standard, there might be a slightly lower threshold to get a CT scan if the diagnosis is genuinely murky. And CT is great. It's really good at spotting subcutaneous gas and fascial thickening, but it can't replace the OR. All right, let's move on to Section 4, management. Once that diagnosis is made, or even just highly suspected, it's time for an immediate, aggressive, three-pronged attack. You hit this infection from 3 directions all at once. And these are the 3 pillars that you absolutely cannot negotiate on. Number 1, aggressive fluid resuscitation, just like you would for any septic patient. Number 2, broad-spectrum IV antibiotics, and they need to be on board within the hour. And number 3, the most important one, urgent, radical surgical debridement of all that dead and dying tissue. And just to be clear, these don't happen one after the other. They are all happening at the same time. Now let's look at the antibiotic cocktails, because they are very similar, but there's one really key difference. Both sides use a heavy-hitter broad-spectrum agent, something like piptaz, and both include clindamycin, which is absolutely vital because it helps shut down the toxin production from the bacteria. But here's the split. US guidelines almost always add vancomycin or linezolid right from the start, and that's to cover for the higher prevalence of MRSA over there.
And the surgery, well, it's not a one-and-done deal. Not even close. The patient has their initial radical debridement, but they have to be scheduled to come back to the theater, usually within 24 hours, for what we call a second look. And this cycle of washing out, inspecting, and debriding more tissue gets repeated again and again until the surgical team is absolutely confident that all the necrotic tissue is gone and the infection is finally under control.
Okay, here's another interesting point of divergence: hyperbaric oxygen therapy. The UK guideline is, well, it's pretty blunt. It says the evidence is weak and it advises against using it. The focus should stay squarely on surgery and medical management. The US guidelines are a little more permissive. They mention it as a potential adjunct, something that certain centers might use, especially for gas-forming organisms, but it's definitely not considered standard practice.
So let's say the team has finally gotten the infection under control. The battle is far from over. For the survivor, this is just the beginning of a very long, very difficult road to recovery. I mean, the postoperative phase is a massive undertaking. We're talking ongoing ICU support, maybe organ support, you need aggressive nutritional support, you've got complex wound care, often using things like vac therapy. Then there's the planning for huge reconstructive surgeries down the line, skin grafts, flaps, you name it. And on top of all that, intensive physical rehab. But critically, and we cannot forget this, there's a psychological toll. These patients often suffer from severe PTSD and depression. They need dedicated mental health support just as much as they need the surgery.
Okay, Section 6. After digging into all those differences, let's bring it all back home. What are the universal, non-negotiable truths of managing necrotizing fasciitis, no matter what hospital you're in, no matter what country you're in?
These are the 4 big ones that you have to take away from this. First, maintain a high index of clinical suspicion. Always have it in the back of your mind. Second, resuscitate early and resuscitate aggressively. It saves lives. Third, and this is the big one, do not delay radical surgical debridement. And finally, number 4, understand that survival is just the start. The journey requires a comprehensive, multidisciplinary team to see the patient through. And that leaves us with one last question to really think about. When you're in that gray zone, when the diagnosis isn't totally certain, which is the bigger risk? Taking a patient to the OR for a negative exploration, or delaying and potentially missing a galloping necrotizing fasciitis? The answer to that question really says everything you need to know about the philosophy behind treating this absolutely devastating disease.